Dengue fever comes under viral hemorrhagic fever caused by dengue virus, coming under the family arbovirus flaviviridae. As it is an arbovirus, it is transmitted by the vector Aedes aegypti mostly, and another one is Aedes albopictus. Aedes aegypti is a more efficient vector than Aedes albopictus because Aedes aegypti needs multiple hosts for completing the life cycle, while albopictus needs only is more aggressive and needs only one host. Therefore, more efficient transmission is through Aedes aegypti. The mosquito acquires the infection by biting a person with the viremia. Then, after an extensive incubation period, about 8 to 10 days, the mosquito become infective, and throughout its life, it's infective, and it can transmit the infection to its daughter cells also. Therefore, there is trans-ovarian transmission. The transmission cycle involves both man and mosquito. The pathogenesis of dengue fever. It is first when it's first infected, it is called the primary dengue fever, and subsequent infection is called secondary dengue fever. The pathogenesis of dengue fever involves antibody dependent enhancement. That is, as we know, dengue virus can have 5 serotypes, that is DN1 to 5. So if a person is infected by DN1, both neutralizing and non-neutralizing antibodies are released by the body. The neutralizing antibodies are effective against this serotype and gives protection to the organism, and it stays lifelong, but cross protection to other serotypes diminishes after a few months. The non-neutralizing antibodies last lifelong and are heterotypic in nature. That is, they are produced against other serotypes but not against the infective serotype. Therefore, on subsequent infection by another serotype, for example DN2, the non-neutralizing antibodies protects the virus cells from host immune system by inhibiting the bystander B cell activation against the second serotype. This is called antibody dependent enhancement. The non-neutralizing antibodies promote recruitment of mononuclear cells, for example macrophages, which causes further activation of cytokines, which causes the most severe severe infections such as dengue hemorrhagic fever and dengue shock syndrome. The clinical classification of dengue fever, based on the traditional classification, there are 3 types of fever: dengue fever, dengue hemorrhagic fever, dengue shock syndrome. Dengue fever is characterized by abrupt onset of high fever, that is biphasic fever or breakbone fever or saddle back fever. Maculopapular rashes over the chest and upper limbs are present. Severe frontal headache, muscle and joint pains, lymphadenopathy, retroorbital pain, loss of appetite, nausea and vomiting is characteristic of dengue fever. In the dengue hemorrhagic fever, it is characterized by high grade continuous fever along with hepatomegaly, thrombocytopenia, that is platelet count below 1 lakh per millimeter cube, and raised hematocrit by 20%. Evidence of hemorrhages, that is positive tourniquet test, more than 20 petechial spots over the square inch area in a pubital fossa, and spontaneous bleeding from skin, nose, mouth, etc. Then dengue shock syndrome, it is characterized by the symptoms of dengue hemorrhagic fever along with shock symptoms such as rapid and weak pulse, narrow pulse pressure, that is less than 20 mmHg, or hypertension, presence of cold and clammy skin, and restlessness. According to the 2009 WHO classification, it is classified dengue with or without warning signs and severe dengue. Dengue with or without warning signs, the main characters criteria to classify the dengue fever under this classification is that life in or travel to dengue endemic area and fever with two or the following criteria, that is nausea, vomiting, rash, aches and pains, tourniquet test positive, leukopenia, and any other warning signs. The warning signs may include abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, restlessness, liver enlargement, and increase in hematocrit concurrent with rapid decrease in platelet count. Also, laboratory confirmed dengue, important when no sign of plasma leakage is present. This requires strict observation and medical intervention. Severe dengue, which involves severe plasma leakage, severe hemorrhage, and severe organ impairment. Severe plasma leakage leading to shock, dengue shock syndrome, fluid accumulation with respiratory distress. Severe bleeding as evaluated by clinician, causing hemodynamic instability and may require blood transfusion. Severe organ involvement, liver, that is AST or ALT more than 1000, and CNS impaired consciousness, and heart and other organs. The type 2 is apparently more dangerous than other serotypes. Perinatal transmission of dengue fever is possible. Therefore, if a mother is infected, a pregnant woman is infected with dengue, the child born will have thrombocytopenia, ascites, or pleural effusions and fever. The laboratory diagnosis involves the NS1 antigen detection. NS1 antigen detection by ELISA or ICT RAP, that is rapid diagnostic tests. The NS1 antigen is detectable from the day 1 of the fever and remains positive up to 7 days, and is useful in differentiating between flaviviruses, therefore is highly specific. Antibody detection involves in primary infection, the IgM antibody increase in the first appears in the 5 days of fever and disappears after 90 days, while IgE is detectable with a low titer and slowly increases. In secondary infection, IgE antibody titer rises rapidly. False positive result after recent infection or vaccination with a yellow fever or infected endocarditis or Japanese encephalitis is also seen. Another diagnostic form is the MAC-ELISA, that is IgM antibody capturing, which is type of double sandwich ELISA, that is the using anti-human IgM antibody. The human IgM antibodies are captured, which is reacted with which reacts with the viral antigens, which is then detected by the antibodies and evident biotin complex, which makes the test more sensitive. Another neutralization tests such as plaque reduction tests, microneutralization tests are also available. Rapid diagnostic tests are useful for dengue fever, but has poor sensitivity and specificity. Therefore, RDT for dengue, NS1 or IgM should be considered as probable diagnosis, must be confirmed by ELISA. Virus in isolation is also done, but in research purpose only. Another more sensitive method is the molecular method of detection of specific genes of viral RNA, 3' UTR regions, which can be used for detection of serotypes and quantification of viral load in blood. Treatment: there is no antiviral therapy as such. Replacement of plasma losses, correction of electrolyte, metabolic disturbance, and platelet transfusion if needed. Prevention is by mosquito control measures, and a vaccine is present, known as a chimeric yellow fever dengue, live attenuated tetravalent dengue vaccine, that is CYD-TDV, also called dengue vaxia. It can be given for people who have previously been infected with dengue, of age 9 to 45. 3 injections of 0.5 ml is administered subcutaneously at 6 months intervals. It is in lyophilized form, therefore it should be reconstituted with normal saline. It is contraindicated with people having allergy reactions to vaccines, pregnant women and breastfeeding women, and also immunodeficient individuals, people having HIV and all. Efficacy against hospitalized dengue illness is about 80%.